give a bit of background to the Tameside and then the broader GM programme, what the team did at Tameside, some of the challenges, the outcomes of the programme for residents of Tameside and for the staff on the teams. So we'll introduce ourselves first of all. So I'm Jo Finnerty. I'm the programme manager for adult social care workforce at the Greater Manchester Health and Social Care Partnership. So I'll hand over to Dave first. Do you want to do a bit of an intro?
Morning, everyone. Yeah, I'm Dave Wolfson, team manager on the adult social care commissioning team at Tameside Council, and for the last 3 years or so, I've had lead responsibility for the transformation of home care in the borough. Paula?
I'm Paula Bell. I'm one of the district nurse team leaders in Tameside and Glossop, and predominantly the blended roles has been running from my locality.
Thanks both. Okay, I'll first of all go through, and it's not letting my slide move on. Hang on. Moving. Anisha, do you know anything that I need to be doing to make it move?
No, just give it a second, and if not, I'll get the slide up and I'll do it from my.
Thanks, Anisha. First slide was really just go through a bit of housekeeping. Obviously, due to numbers, there isn't time for us all to do full introductions, but please feel free to use the chat function to do so. It's probably best that we leave questions to the end of the presentation that we'll do, so you can always introduce yourselves as you ask a question. Being recorded, so it'll be available for those people who can't attend. And what we will do, the slides will be made available afterwards as well. So what we've done on previous sessions, if there are maybe a couple of questions that we need to go away and find things out, we can then incorporate that into the slides as they get published. If everybody could please keep their microphone on mute while we're going through, just to avoid any feedback. And then when we take the slides down at the end, then if people can keep the cameras on, that'd be great, so that we can see everybody. Let me just try again to move it on, because it's not going to help if I can't see them. Anisha, did you say you're able to bring them up?
Yeah, if you stop sharing, I'll share my screen and
thank you.
Try that way.
Sorry about that. I don't know why it's not letting me move them on.
It went smoothly when we did it earlier, didn't it?
We had a practice before and it all worked.
Typical.
This looks like we're not prepared. You wouldn't believe the amount of.
Can everyone see that okay?
I can see that, so
yeah.
Everybody else can. So right, okay, let's pretend that didn't happen. Okay, so just to give a bit of background first, really, to the blended roles Trailblazer and from a GM perspective, that's where that came from. It formed part of the Greater Manchester Living Well at Home programme, which is a key priority in the adult social care transformation programme as a whole. And essentially that's about supporting people to live their best life and live well at home, wherever that home is. So whether that's their own home, whether it's a care home, whether it's extra care. And the Trailblazer programme as a whole was brought in earlier last year to really bring together different aspects of the health and social care programme. So you might not be able to see the detail that's in the wheel there, but it covered workforce, person-centred care and support technology, a whole host of different things, and how using sort of rapid testing methodologies we could look at how we develop innovative new ways of working and supporting people, and all of those things, sort of joined together around that. So what that wheel does show, and like I say, we'll share them so you can see better the detail on it, but with the different projects and the localities that trailblaze those projects, the workforce Trailblazer was picking up on work really that had already started in LWAH is Living Well at Home, so that's the programme that underpins all of it. So the work that had already started in Tameside, it was really about maybe getting a bit more pace and development, and then how can we scale that up on a wider basis across Greater Manchester. Could you move on to the next slide, Anisha? Thank you. Okay, so I guess why we chose that Trailblazer, really, we knew, and those of you that work across health and social care will also know. I mean, it's an issue across health and social care, but certainly within social care, significant recruitment and retention challenges for the whole workforce. But what we knew from a kind of deep dive that we'd asked Skills for Care to do for Greater Manchester around the data was that home care particularly was an area where providers struggled to recruit and retain staff. And in addition to that, we'd also identified a number of other things, or Tameside had certainly identified a number of other things. One was that people often reported a disjointed experience of care and support. The different services were delivering different components, meaning that people often had to navigate systems themselves, find their own way through it. And what we did at the very start of this, we had an initial workshop where we looked at some real case studies, so real people's experience, and kind of plotted against it how many different teams were involved in a person's care and how all that joined together. And it was quite staggering, really, the number of people that were involved in that person's care and support from different organisations, different agencies, and really how kind of disjointed some of that was. There was also a lack of, to some degree, a lack of co-production with service users and their families, and the lack of person-centred conversations and limited connection being made with communities. So that was something we wanted to make sure we factored in. Focused on time and task rather than strengths-based approaches to care and support in terms of commissioning care packages, and not having that strengths-based approach to care and support that looks at what somebody's able to do for themselves and what the connections are around them and the community resources before determining a package of care. Mentioned earlier around recruitment and retention, but also communication. Again, I think linked to that first point, communication between health and care professionals was not as it could have been, and that was something that was flagged up by those partners, if you like, within the delivery of that care and support, as well as the people in receipt of the care and support. So that hopefully sets a bit of a scene for the kind of background to it. What I'll do now is hand over to Dave, who'll talk you through what Tameside did.
Thank you. Could the next slide, please, Anisha? Or have? Oh, lovely. Thank you. Right. Yeah. So just a little bit more background, I guess, specifically around the working on home care in Tameside. We'd started at about 2017 to try and shift our delivery model away from essentially a time and task focused approach to a more outcomes focused person-centered model. And we were working with, we have 6 own providers, each of whom work in a geographical area that is sort of mapped against 4 neighbourhoods that we have. So some neighbourhoods have 1 provider, some have a couple of providers, and West neighbourhood, which we'll be talking about in a bit more detail, where we piloted this, have 2 providers. But essentially we were starting to work with our 6 contracted providers to look at changing how we delivered home care, and there was a whole raft of different things that we did, but one of the things that we did early on was to increase the hourly rate so that that was pegged against the foundation living wage. But alongside that, we said, well, with that, we'd sort of want to look at roles and responsibilities of home care staff. So it was at that point that we'd started to think in terms of sort of low-level health tasks and home care workers taking on some more of that. There was definitely an issue around joined up support and the continuity of care. Joe's sort of touched on that already. As we progressed the pilot, you'll see that we cottoned on to the fact that that sort of led to fewer knocks on the door. And in fact, with the whole pandemic in the last 7 or 8 months, that's become something of particular significance in terms of reducing the number of calls that vulnerable people have in terms of COVID. Anyway, all this was happening before COVID, of course. recruitment and retention was a huge issue. And I think when we'd been talking with providers, one of the things that they were saying was that if we could look at ways of improving the image of home care and the roles and responsibilities that staff took on, that they felt that would help with recruiting the right staff and then retaining those staff. And they were both big issues, and we know that you'll all recognise that from where you work as well, I guess. Job satisfaction was in the mix there as well, and career progression. One of the things that we hoped might start to happen when we looked at this was that it would attract people into home care who might have an idea that at some point they would use that as a stepping stone to go on to do nursing training or social work training, but certainly for this particular piece of work, for the nursing training. And then we'd already started the journey around sort of better integrated community services. So we'd had social workers and district nurses in the same room working together for a year or two, but it felt like, you know, you absolutely needed to have your sort of home care workers as part of that integrated approach as well. And this seemed one mechanism for doing that. And I guess something that Paula was very aware of in all of this was freeing up some district nurse capacity. We knew from our conversations with our district nurse teams that they were extremely busy, and that that was a real pressure in the system for them. So all in all, that led us to start talking about a pilot in West Neighbourhood in the summer of 2019. Could we have the next slide, please? Right, so we wanted to just sort of summarise some of that, to find a way of home care staff and district nurses working more closely together. And the focus was on low-level health tasks that district nurses do, but which you don't need to be a district nurse to do. So crucially, that was tasks that individuals and family members already were sort of routinely or periodically shown how to do. And then within we came up with a list of maybe half a dozen or so tasks, but the one we chose to focus on was pressure area care and sort of basic wound care and body mapping and skin observations. So with Paula, who's the team lead for the district nurse service in West, and with the two providers in that neighbourhood, Creative Support and Comfort Call, we started to look at how we would take a sort of blended role, shared care approach. Could we go on to slide 7, please? Thank you. Right, Paula, please jump in at any point on this one.
I will.
Okay, so there's a whole bunch of issues in there, Paula, wasn't there, that we wanted to try and get to grips with.
Yeah.
I think one of the interesting things was that home care providers and their home care staff had been saying for some time, or asking why they couldn't get involved in some of these sort of tasks. And in terms of a sort of person-centered approach, that sort of rang some bells, really. It felt like that if we could get home care workers and district nurses working closer together, that would sort of tackle some of that stuff. And communication was a big part of that. So you know, one of the things that would routinely happen was that home care workers would perhaps notice that someone they provided care and support to had some issues with their skin integrity, would maybe ring the district nurse number. 9 times out of 10 they'd leave a message because the district nurses were busy and out, and often the district nurses wouldn't be able to return that call for a day or two. And of course, in that time, often that individual's skin might have deteriorated, and that could have led to them, you know, being admitted to A&E or even to hospital. So we sort of looked at how we could tackle some of that. And as we go through some of the things that we did, one of the things that we did was, as we linked up named district nurses and a named key worker, they've swapped phone numbers, and a really simple thing to do, but it a stroke helped improve that communication between two sets of workers. And then this might be one of the points lower down, but we arranged for home care providers to attend weekly team huddles with the district nurses and social workers, where that hadn't previously been happening. And so the providers were able to sort of become a part of those conversations regularly. I mean, that was.
Sorry, Dave. I think certainly as part of this as well, we wanted to be very sort of specific in saying that we're working with the care providers. However, we don't want to give them any added pressures on such a demanding job anyway. We wanted it to be a joint working where we were all communicating together for the same outcome, for that person-centred care, individualised care, and it was working in a way where we were freeing up district nurse time to sort of direct more complex patients within our caseload, but also supporting the care workers in providing a little bit more of a sort of individualised care based on that person they're seeing. So it's facilitating that. So as part of that, we did training sessions which were surrounding pressure ulcer development, the contributory factors such as your nutrition, skin integrity, continence, those types of things, just quite basic things. But as our training sessions developed, the feedback we were getting from the carers was immense, really, and how they felt listened to, and just little tips really and hints from the district nurses were making their lives easier, which made a big difference. And in doing that, the relationship built between the care workers and the district nurses greatly, and I think that has been the key thing we've taken away from this.
It definitely has, Paula. It's been lovely, that bit, hasn't it? With home care workers have really sort of appreciated the fact that they feel much more part of your team and an integrated approach. Hello. You still there, Paula?
Yeah, sorry. So we chose, as part of the approach of the pilot, we chose, as Dave said, there was a select number of people we sort of targeted, and it was those that were known to both services who had, a number of issues that we were seeing for district nurse point of view, where we could reduce some of those visits and hand over, if you like, to the care providers. Chance to add on that one, Dave?
Yeah, just to quickly mention the care bundle that you developed, Paula, really, because I think that was sort of key to this, really, that Paula and her colleagues came up with a suite of planning documentation for use across, the home care providers and the district nurses.
Yeah. As a way of assurance, really, it was more the shared care plans, we've called them, the care bundle. So there were specific care plans that we could generate, and they were individual to the patient need. We'd go through that care plan, and it'd be very simple, step-by-step instruction as to what we would want the carers to provide for that patient. So that was in particular surrounding, if, for example, pressure area care, how to body map, what kind of things would contribute to that person's skin breakdown or skin integrity, looking at the types of equipment, just for reassurance and for obviously for both parties. We developed a competency document, so the district nurses would go in, and yeah, it's timely, but in the long run, we're reducing those visits that the district nurses will make. So we'd go in and we'd deem the care worker competent to carry out that particular task that was written in that shared care plan.
I think that was a key part of this for us, really. So the competency sign-off is specific to an individual service user patient. So each patient has a named district nurse and a named key worker, and that named key worker is signed off as competent only for that individual. So, so that means potentially a home care worker might support two people living next door to each other on the same street who have similar issues, but unless they're signed off competent, they're only signed off competent for the individual that they're the named key worker for. So although they might have those skills and competencies, the sort of approach only works because the competency is signed off for that individual.
Mm-hmm. And I must stress as well here that ultimately the district nurses are still accountable for that patient. They're still on the district nurse caseload. So by going in and deeming competent, we still overall are overseeing that aspect of care. We're not handing it over and discharging and moving on. They're still part of the DN caseload. It's just that we're reducing the number of knocks on the door and reducing the capacity, really.
I think that's picked up in the next slide, isn't it? Hopefully.
Is it really? Sorry, jumping the gun.
No, I just, because it was quite significant, some of the outcomes we saw there. Can we have a look at the next slide, please, Anisha? Thanks. Oh, perhaps it's not this slide. Anyway, we ran the pilot over the summer of 2019. We were all set, to some extent we've carried that on, but we were all set to roll it out across all 4 neighbourhoods as we were coming into the start of 2020. But of course, the pandemic's got in the way of that. But in terms of the pilot itself, we were getting some really interesting and quite significant feedback in terms of staff involved, appreciating and feeling very positive about the difference it made to their sort of work satisfaction, and that applied to district nurses as well, Paula, didn't it?
It did, yeah.
And I won't read through that quote, but basically home care workers were sort of commenting routinely on what a difference it made in terms of their approach. Next slide, please, Anisha.
So this was really relating to how the district nurses and the care providers sort of communicated away from the patients and how we sort of developed that relationship. So as part of our safety huddles within the district nurses, we then began to sort of join them in with the safety huddles. So it wasn't necessarily just discussing the people that they had shared care bundles in with, it was the wider service, and that was an opportunity really to pick up on other service users, patients. We never got a happy medium with that term, did we? But we just to be able to sort of discuss other patients on the caseload that we thought may be appropriate for this way of working, and that is something that we're still ongoing with that. Obviously with COVID, everything's been very stop-start, but it is a passion of ours to keep this moving and try and get more and more patients signed up to this across the organisation. So by doing the joint up team meetings, the care planning, etc., it did reduce, as it says on there, it reduces the risk of the poor communication. And as I've already sort of mentioned, the communication has been key, really. The relationship building between both services has really made a difference across our integration on the service that we're providing. Can we move on to slide 10, Anisha, please? So these, this slide gives us a little bit of sort of a facts and figures, really. So initially, when we started the pilot, we based it on 40 people that required high level of pressure area care support. It was estimated over a full year this would result in 205 fewer district nurse visits, 21.4% reduction, which equated to 51 hours of patient-facing time, which could be repurposed to meet demand. The approach was rolled out across our neighbourhood, as Dave's already mentioned, and over that period, 957 fewer district nurse visits will be required, freeing up 239 district nurse hours to, as I say, repurpose to more complex needs. Now, obviously, COVID did change that slightly because of obviously the pandemic, the situation in itself. A lot more carers were taking on some of the care tasks, the low-level care tasks, without having some of the care bundles in place. I say carers, it was probably more relatives because we were trying to sort of reduce footfall given the circumstances. But ongoing, I think this is going to make a big difference to the district nurses caseload across multiple organisations if this data continues, really.
Paula, if I remember right, one of the things that I think you were saying at the time was that, as a rule of thumb, where you district nurses were going in weekly, with using this approach, that was able to go to fortnightly. Where you were going in fortnightly, that was reduced to monthly, wasn't it? And that,
that's how we originally sort of where we pulled the data from and how we got our figures, really, and that was based on sort of an electronic caseload and schedules that were set up. So that is where we got that data from initially. We move on to the next slide. Thank you. So I think the steps in Tameside prior to COVID, we were just at the point where we were rolling out to our neighbouring localities. We did set up sort of working groups within those areas, and then COVID hit, so things have come to a little bit of a standstill. However, the theory's still there behind it, and you know, the team leads, certainly from a district nurse perspective, have taken the care bundle away and are implementing it gradually across their areas. I'm sure Dave will tell you about the insulin pilot that was piloted as well in South.
Yeah, that again, that's on pause, but that was based on a small pilot that happened in South neighbourhood in I think it was 3 or 4 care homes where the district nurse trained care workers in those homes to deliver insulin via a dial-up pen, and I mean, it was a very small little pilot, but the outcomes from that were pretty impressive, really. So the intention was to try and to do the same in South neighbourhood, and we'll pick that up when we're in a better place, maybe next in the spring. But it would be working on pretty much exactly the same model in terms of refresher training and training for home care staff from the district nurses, and then competency sign-off using the care bundle. And in fact, just below on one of the other bullet points, there are some of the other tasks that we've sort of looked at and have got in mind for the future.
Yeah.
Okay, do you want me to now pick up, I suppose, what's next? So obviously what Dave and Paula have gone through is the incredible amount of work that they did at Tameside to get that programme up and running, and it was really just to sort of finish off the slides with a what next in terms of the Greater Manchester programme. So in summary, all the localities are at varying stages of kind of preparation and you know, thinking about where best to implement and the rollout. Bury, and I know we've got people on the call from there on the session from Bury, are poised to implement in the north of the borough with an independent sector home care provider and a district nursing team. Really, again, similar to Tameside, literally ready to go and launch on the 1st of April. So obviously that had to pause, but now very much sort of, you know, up and making preparations to go with that again. Just that very last point was, I guess, based on some of the real success factors of the Tameside programme, which Paula and Dave have gone through around that whole sort of integrated approach, the joint working, the communication improvements, all of that happened as part of that programme. And what we've been fortunate to get is some additional funding through Health Education England to create a role that will really, I suppose, enable us to speed up some of that spread across Greater Manchester. So it's in the stages of kind of developing the role, but it would be a district nursing, it would be a role within the district nursing team, and that will facilitate education and training across Greater Manchester, probably through a train-the-trainer type model, but very much the strong focus of that role will be about relationship building across district nursing teams, independent sector providers and other community-based resources to sort of start to embed that more broadly across Greater Manchester. And very much, I guess, it's about shifting those relationships between community-based partners within neighbourhoods, make sure that everybody's voice is heard and equal in terms of those teams, and everybody's expertise matters and feeds in support to the individuals. So go on, Dave.
No, just quickly, partly that one of the problems that we did find in the pilot, I think, was that although we really liked the idea of Paula and her team doing the refresher training, it was problematic in terms of freeing up their time to do that, and hence this role really came out of that, I think, because we recognised that it was the right thing to do in terms of having a district nurse input in that, in terms of that relationship building and making the sort of connections between integrating the two approaches. But it was a challenge, wasn't it, Paula?
Definitely. Yeah. That was one of the barriers, because you're trying to do that alongside your clinical role as well. But I think you're quite right though, Dave. The district nurse team know their patients and they know their care providers best. So having an external trainer probably wouldn't be as good as doing it yourself and building those relationships. It was sort of a way of sort of working both aspects, really. So yeah.
You're right. I agree.
Okay. So that concludes the slides that we were going to go through. I'm conscious there's a few, and I've been jotting them down as we've gone along. The questions in the comments box. So we'll maybe go to those first. Dave, there are a couple around the commissioning of it, I suppose. So in terms of independent sector providers, the question was around, were they commissioned differently to do the work differently? And a question that's just come up was about whether the pilot was funded via transformation funding. So probably those two can be addressed together.
Yes. So this was in the. I think I said right at the start that we started the work in terms of trying to shift the delivery model in around about 2017. And in fact, what we'd done prior to that was that we'd re-tendered the contract in October 2016. And what we did during that tender was we sort of sketched out in sort of broad brush terms what we wanted to do in terms of shifting to a more outcomes focused approach. And so I think partly, or perhaps largely because of that, the 6 providers that we ended up contracting with, there was really good buy-in to what we wanted to do. And although we didn't actually know a lot of the detail about what we wanted to do, we sort of knew where we wanted to be, and have been on that journey ever since with the providers. So that buy-in was there right from the start. And we had indicated right at that point that one of the things we'd want to look at was sort of low-level health tasks. We didn't at that point have a sense in practice how we do that, but we knew it was something we wanted to look at. And so when we started that work in 2017 and 18 with Paula, providers were absolutely on board with that right from the start. They knew it was coming. They wanted to do it. It was something that made sense to them, really. So I think having just the 6 providers to work with in terms of the zones made that that little bit easier, I think. Not least because providers were happy and comfortable working together and sharing good practice and sort of problem solving together with myself and with Paula. So that was a big help. In terms of transformation monies, yes, we did have. I think we had just over 3 million from the GM transformation monies, which the bulk of which we used to increase the hourly rate that we paid providers, so that they in turn were paying their home care staff the foundation living wage. So we managed to stretch that out over, I think we're just coming to the end of it actually, just over about 4 years. But that was a key part of it, to be fair. I think increasing the hourly rate in terms of addressing all sorts of issues around recruitment and retention has started to pay off, really.
I think one of the things, Dave, that you saw with that, wasn't it, from a workforce perspective, was that the churn of staff around different providers. What providers were reporting was that sort of slowed down because there was a consistent rate being paid across all. Yeah.
Absolutely. Yeah. So prior to that, I think providers paid different rates, and one of the things that we saw was that often perhaps less good home care staff knew that they could leave one provider on the Monday and start at another one on the Tuesday, and that churn happened quite a lot. Now, I think what we've seen over the last couple of years or so, is that that's all but stopped, really, because providers are much more inclined to talk to each other about those sorts of things. Because they're better able to recruit better quality staff in the first instance and sort of retain them. There's less churn anyway, so they're sort of less inclined to take on staff who have perhaps left under a cloud another provider. So that's a lot of that stopped. And in fact, one of the things that started to happen is that they're actually signposting potential staff to each other, so that, for example, if someone approaches a provider in Hyde but they live in Ashton, the Hyde providers will actually say to them, you're probably better off speaking to Careline because they work in the area that you live in. And that, I mean, that's a huge thing, really, that's changed really in the last couple of years, and I think is largely linked to that.
Okay. A few other questions that popped up earlier as well, Paula, probably for yourself, around the district nurse sort of side. So did the district nurses require training to use the competency framework? That's the first of those.
The district nurses, no, we developed the competency framework, so it ties in very much with what the district nurses are provided with when they join our service. So it's based on our clinical induction competencies that we use. So we adapted them to be more sort of user-friendly for carers, and based on the individual tasks that we would be doing with those carers. So the district nurses were already competent, obviously, in those areas. They were then deeming competence with just a simplistic competency form.
Thanks, Paula. And a follow-up question was around how many individual staff did we need to sign off competencies for, if each patient and carer needs an individual competency? So I think Julie, that was your question. Is that around getting an idea of scale of what that involved for the district nurses?
That's right, Jo, because obviously in Bury we were just ready to launch in April, and obviously we've got the competency frameworks ready. We've done some training but are needing to refresh because of the big gap. And that was another of my questions, Paula, is around, obviously we've got competency frameworks, but we were training each individual carer rather than a carer specific to an individual. That's going to have a big implication if we need to do it that way.
Yeah, well, I suppose the way I looked at it was that patient was on the district nurse caseload, so we would be visiting whether they were known to carers or not. So we, in the longer term, we thought, well, by investing investing that time in going and meeting with those individual carers, and we were very sort of an advantage really, because the carers that are going into the majority of ours are set carers. They see them sort of day in, day out, with the mix of maybe the odd 1 or 2 for annual leaves, things like that. So certainly the ones we've done so far are sort of a very regular set of carers that have been going in. As I say, going back to the district nurse caseload, if we're going in anyway, yeah, it may be that we have to go and do initially extra visits to deem competence with a set number of carers, but in the grand scheme of things, I do think that will work out better for the district nurses with a view of capacity in the long run.
And again, your training, I mean, we're really struggling to free up time for the DNs. We really wanted to deliver it. We had to go external and use an external trainer, which was it was February, and obviously it didn't roll out in April. It really probably didn't meet the needs for the carers. So we're looking at doing it again, but to try and free up my DN leads to be able to support this training is really difficult, especially at the moment in the middle of the second wave. We're still in pandemic mode. And I'm sure you know, district nurses. How did you manage to do that, Paula?
Well, that was the challenge. It was basically me and one other person. So obviously, if you think we're just doing this for my locality at the moment, but I did this in between my clinical roles. So I did a lot of it in my own time, you know, off scene, sort of the care bundles and the development of that I did in my own time. But the actual face-to-face clinical training sessions, we condensed them to around 45 minutes to an hour maximum, and that included any questions, answers, discussion at the end. We never sort of set it that you've attended, so you know you never come back. We left it open. If you don't feel comfortable, you come back until you do feel comfortable. All the contact numbers were provided, you know, if ever you've got any questions, we're approachable, we're accessible. So and I do think by doing it face to face and getting to know those carers, because you see them bobbing in and out of visits all the time, that was the key really to building our relationship. But it is very, very difficult to free that time up. I'm completely with you there.
I think that's one of the
Go on, sorry.
I was just going to say, I think that's one of the things we're hoping that this I can't remember what we're going to call it.
The new role, yeah.
New role will address. I mean, it won't be quite the same, in as much as you'll perhaps not have quite that local flavour that Paula had in West. But I think the fact that, you know, it will be a district nurse, and there'll be that sort of understanding about the context in which it's happening should really still be a plus point in all that. And then hopefully that post holder will have much more time and capacity to do some of that training. Because Joe had mentioned some of the issues that you'd hit in Bury, Julie, with your sort of external provider, and it feels like this might be a sort of a good halfway house, really.
Well, what we've done now, Dave, is next week we've got a meeting, and we've got the actual agency that we're using have offered up some of their own providers that does the training. So what we're going to do is try and do a blended training with district nurses, our TVN, and their trainer, to develop something that we can all dip in and out of, because we just couldn't free enough of everybody's busy, aren't they? So that's how we're looking now to do it a little bit differently. So we'll see if that works.
No, that makes some sense. I could definitely see that.
Paula, could I have your email address? If we get into any difficulty, I can email you.
Absolutely. I'll put it on the chat.
Thank you.
Okay, I think there are another couple of questions. They've been popping up, so I've been trying to keep track of them. I know, Jane, I think you'd asked a couple of questions. One was around sustainability, really, wasn't it? So if the transformation money had ended, is it now self-funding? And then another question about the sort of scalability of it, considering the time commitment that Paul has talked about. So I don't know, Dave, do you want to pick the first bit of that up?
I'm not sure I fully understand. Just check. Can you just read the question again?
Sorry, the first bit of it, it was around, now that the transformation money that underpinned it initially has ended, is the model now self-funded? So I suppose is that the big question?
I hope so. There was a funding gap. There's absolutely doubt about that. But what we managed to do over the last 2 years or so is kind of, and it was, it took a lot of discussion with particularly our health finance colleagues, but because we've got a pooled budget, what we were able to do was sort of say, look, if we're going to deliver proper integrated care, having a good, sustainable, well-functioning home care service is a cornerstone of that. We need that to happen. By doing work like the blended role stuff and some of the other things that we've done, we think that we can take the heat out of some of the other parts of the wider health economy, like reducing the number of hospital admissions or the length of hospital admissions or A&E tenancies and those sorts of things. And after a good 2 years or so of having those conversations, that's where we're at. We've reached a point where there is funding now available sort of internally within the pool budget to cover that. And in many ways, I think that the pandemic has sort of strengthened some of those arguments, because what you see is, where as hospitals have needed to discharge people, we've had providers who admittedly are working at full stretch and are under all sorts of stresses and what have you, but they've risen to the challenge. And I'm not sure that they would have been in quite the same position to do that had we not done some of this work previously. In terms of consistency of staff, the reduction in the sort of turnover of staff and the quality of staff as well. So it wasn't easy. And there is a significant financial element to all of that. But I think having a pool budget and sort of having those conversations in the round, I'm sort of simplifying things, obviously, because they were quite complex conversations to have. But ultimately, that's where we've reached. What was the second question, Joe? Mine, or was it?
I think we might have probably covered it. I've just had a quick look through the questions. I think some of the earlier questions as well might have been answered through some of the later answers, if that makes sense. If there's anybody on the call that's put a comment in that they think's not been covered by some of the responses, it might be as well to either virtually or if you actually stick your hand up, I don't think I can see most people, so virtually put your hand up if you think there's anything we've maybe missed when we've gone through some of the responses. Oh, Jane?
My question is still about scalability, and considering it sounds like a brilliant model, don't get me wrong, but obviously the time investment and the cost pressures up front, are you scaling this up across the whole of your integrated care partnership, and the anticipated time frame that will take in order to then see the outcomes, which is what we're looking for, those integrated outcomes? How's that going to work?
We were just about to, Jane. We had working groups in place throughout. Well, I think we started in about December 19, and they were sort of running. We paused them in March. So I think we were hoping that sort of rollout would take, maybe 6 to possibly 12 months, most of this year. But obviously we can't say that for sure now because we've had to pause it all. But Paula, I think one of the things that it would be interesting to get your view on, but I think what we saw at the start of this was that district nurses, it took a little bit of time to sort of to get to a place where trying this made some sense. But as soon as we did start working on it, what we saw from the pilot was, the sort of from a district nursing point of view, it really did start to make sense at that point, because it had that potential to free up so much time to sort of reuse and repurpose elsewhere.
Yeah, no, you're right. I do think from like the scalability point of view, I think certainly in Tameside, because we've done this and we've done it as an addition really to, well, me personally as an addition to my clinical role, and being able to do that, I think obviously we've got sort of buy-in really from sort of more senior leaders, and the more aware of sort of the changes that we can make really towards the service, and how we can increase sort of time for more complex care, which is what district nursing is all about generally. So I think the buy-in we're getting from senior management is a lot more than we did in the early stages. So from a scalability point of view, I do think we'll have more invested time and protected time to enable us to do that across our localities, from sort of a team leader level, band 6 levels. I think what we're hoping to, and it will tie in nicely with the new role, is to have sort of leads in each of the area that will sort of work on the pilot in each locality to sort of ensure that's implemented and embedded as we want it to be.
Jane, I think the other thing is the buy-in from providers, that you know, we'd almost sort of reached a kind of point in time where to not do this wouldn't make sense in terms of the context of, you know, an outcomes person-centered approach. That providers absolutely see the value in doing this in terms of their ability to recruit and retain staff, which is, you know, just been such a huge issue for them always in terms of a kind of sustainable approach to home care. So in a sense, although this was a pilot and you could sort of see it as a sort of piece of work on its own, it's also part of a bigger, a wider sort of whole, really, sort of whole systems approach, if you like. That we've taken the view that if you're going to have a sustainable home care model and support more people living in their own homes, then you have to do things like this. Otherwise, you know, that's sort of, I don't know, the more traditional sort of approach to home care isn't sustainable. You know, prior to this, we had providers who, you know, were really struggling. And don't get me wrong, it's still a challenge, but I think that they've recognised and see that it's things like this that help them deliver home care differently and do the things that they need to do and want to do.
Thanks, Dave. Has anybody got any? I think we've covered most of the questions. Conscious we've got 5 minutes of our slot left. So has anybody got anything else that they'd want to ask before we finish the session?
Can I just ask something? Yes. Sorry. Going forward, do you see if there was a health and social care qualification that took into account a more blended role? Do you see that as a way forward? You know, you were talking about sort of the time constraints in doing all of this training. Do you think that having a more tailored qualification for care workers might be a way forward for the future?
I think it's a potential. Yeah, I mean, how that would look, I don't know, with regards sort of the obviously the financial aspect of it, because obviously with the care workers, care providers at the minute, they've got that enhanced rate of pay, haven't they, at the moment, which incorporated them taking on more tasks. But yeah, I think I do think that'd be a good idea. Sort of a clearer pathway really for education and sort of further training, I think would be really good, because something that we, you know, as I do a training session, we do talk about, you know, career progression and where potentially that could lead, because you've got some fantastic carers out there who just don't know where to go next. And sometimes all they need is that little chat with someone just to give them that little bit of passion to sort of take that forward. So I do think that would be a really good idea, yeah.
I think we not specifically linked to this, Anne. We did introduce probably about 12, 18 months ago, and I've lost track of how many modules there are in the home care training, an additional module around person-centered approaches. So it wasn't specifically about blended care, but I think that was partly in recognition that, you know, that it would help to have something like that. And in fact, some of the conversations I had early on with the HR at the trust, you know, they really sort of understood and got that if you can help attract more people into home care who may then in turn come through into nursing to do their nursing training, then that was a good thing as well. So it feels like there's definitely some mileage in it. It's not something we've particularly had the opportunity to look to sort of progress though.
And I think that additional element, I know Jay's just asked about whether the care certificate could help. That additional element was an additional care certificate component, wasn't it?
Well, that's right.
16 sticks in my mind. I don't know.
I thought it was 16.
I do recall that now, actually. Yeah, I do. Yeah.
I think it was, a separate sort of, it was an addition, wasn't it, to the care certificate? We're probably down to our last question, I think, now. And Anne, is your hand still up from that question before? Yeah, that's fine. Jane had also asked about the additional tasks. So were they additional tasks similar to the tasks that healthcare assistants deliver? So Paula, that's probably one for you.
So do you mean the additional tasks as in sort of the next level tasks, Jane?
Tasks that the care workers were conducting, are they similar to what the HCAs would conduct in the community? And that's why I was thinking about the care certificate link.
Yeah.
You know, how we would make this work.
Yeah, well, some of the tasks are something that the healthcare assistants would go and carry out. Not necessarily all of them. We'd have registered nurses going in, but again, that's based on sort of the freeing up of the registered nurses to go and be able to do the more complex cases, really. So yeah, the care certificate probably would be beneficial to undertake for the care providers. Yeah.
Thank you.
Okay, so I think we've now covered all the questions. As I mentioned at the beginning, the slides will be made available. And I think, Anisha, will something go to participants to explain how to access those later?
Yeah, at the very beginning of the chat, there is a link to Workforce Future Centre.
Okay, so that if you follow that link, there will be access to the slides. What I will do is make sure there's nothing we didn't maybe cover that we could perhaps add in, because I'm conscious some people had to leave a little bit earlier as well. But I've really enjoyed the session. It's been great, and thanks to Dave and Paula for sharing their wealth of experience around this, and thanks to everybody for joining the session.
Thanks, everyone.
See you all soon.
Thanks, Joe. Thanks, everyone.
Bye.
Bye.